Just a brief overview of antibiotics. All of you are familiar that the antibiotics can be bacteriostatic, where they don't kill the bacteria, but they prevent their multiplication, or bactericidal, which are the stronger, more potent antibiotics which kill the bacteria. And you can have broad spectrum or narrow spectrum. And you have the different antibiotic classes, so aminoglycosides, cephalosporins, tetracyclines, and so on. We have the different mechanisms of action. So we have a couple of slides detailing that. So basically you have the cell wall inhibitors. So the penicillin, cephalosporins will inhibit the cell wall synthesis. The carbapenems as well inhibit cell wall synthesis. Sulfa drugs are not much used, but they inhibit folate synthesis. The fluoroquinolones inhibit the DNA replication by inhibiting DNA gyrase enzyme. The tetracyclines, macrolides, and aminoglycosides all inhibit protein synthesis. So you have the lincosamides like clindamycin, which inhibit protein synthesis as well. And of course, in the Indian scenario, we have a lot of drug resistance. So we have to be all very responsible in how we approach antibiotic treatment. So the WHO has classified antibiotics into three categories. We have the access group like ampicillin and gentamicin, which are the first or second choice antibiotic. They are the best therapeutic value and minimize the potential for resistance. We have the watch group, which is the second choice. Most of the time you would go to that where you have specific infections you want to cover. The third generation cephalosporins and some of the newer aminoglycosides, ciprofloxacin, these are all in the watch group. The reserve group is a last resort like meropenem and colistin, polymyxin, and so on. So you don't want to use these drugs unless vancomycin as well. So you don't want to use these drugs unless you have a clear indication. So these are examples of the access and watch antibiotics as well as reserve. So these charts are available and you can get this information online. But I gave you some examples as well. Linezolid, for example, comes under the reserve category as well. And fluoroquinolones are in the watch category. Macrolides are in the watch category as well. So we have examples of these, and vancomycin is in the watch category, while linezolid is in the reserve category. We have different levels of drug resistance. So you have these classification of antibiotics. So aminoglycosides, carbapenems, cephalosporins, fluoroquinolones, anti-pseudomonal penicillins, monobactams like aztreonam, and phosphonic acids, phosphomycin, and polymyxin like colistin and polymyxin B. So we have multi-drug resistance where you have resistance to one agent in three or more of the antimicrobial categories. So if you have more than three groups which are resistant, it's multi-drug resistance. That's a common category, like the routine ESBLs. Then we have extreme drug resistance, where we have resistance to one agent in all but two categories. So for example, if the antibiotic sensitivity covers these, you have like two categories which are still available. It is extreme drug resistance, and you have pan drug resistance, which is something which hopefully we should not see, but we do see some bacteria where almost all the groups you have resistance to all agents in all categories. So pan-drug resistance is the most severe. Multi-drug resistance is also bad. And you know the mechanisms of drug resistance. So we have the bacteriophage-related multi-drug resistance, and you have the other mechanism, genetic mechanisms, plasmid-mediated as well. So different bacteria, Enterococcus is quite resistant. We even get vancomycin resistance now in 20% or so. Staph aureus, we often see MRSA, and vancomycin becomes essential in such cases. Klebsiella is carbapenem resistant in many cases. Acinetobacter, Pseudomonas, which is resistant to ceftazidime and many other agents. And Enterobacter can be resistant as well.